Today, this is the 21st module, and we have Dr. Najidya from Government Medical College, Thrissur, who will be presenting a case, and Dr. Mallika, Professor of Ophthalmology, again from Government Medical College, Thrissur, will be the mentor. And as an external, we have none other than Dr. Rajashekar from Chennai. Welcome, sir. On behalf of Scientific Committee, warm welcome to the PG classroom.
Thank you.
As we all know, this program is basically for the postgraduates. And as sir was telling, like most of the PGs know the case and they are academically also strong, but they don't know how to answer the questions when the examiner asks, and they don't know the correct terminology. So the basic aim of this program is to train them to present a case, even though they know the subject, the present day case very well. So with these few words, I hand over the program to Dr. Mallika, who is the moderator of today's program. Over to you, Dr. Mallika.
Thank you, Dr. Bastin, and thank you, KSOS and Dr. Bastin, the Scientific Committee Chairman, for this wonderful opportunity. With great pleasure, I would like to invite today's main discussant, who is the external examiner, that is Dr. Professor Rajashekar Karpasamy, and I would like to give a brief introduction to Sir. Professor Dr. Rajashekar Karpasamy is a retinal surgeon and a renowned scholar teacher, uh, being attached to the Bicentennial Regional Institute of Ophthalmology, which is attached to Madras Medical College. He had also worked as the Deputy Director of Medical Education, involved in the National Medical Council affiliation and approval of UG, PG, and super specialty seats in Medical Council of Tamil Nadu. He has been interested in inculcating and nurturing quality ecosystems amongst the government tertiary care hospitals. Sir is also a key member of the Continued Medical Professional Training Development Program, TANQuest, in Tamil Nadu. Sir has also served in various capacities in TNOA and Tamil Nadu State IMA. With these few words, I would like to invite you, sir. Over to you, sir. And
Thank you, madam.
is it okay that Najidya can start presenting her case?
Yes, madam. Once we start presenting, we'll continue with the discussion. Yeah.
Thank you, sir.
Can I start?
Yes,
Yeah.
ma'am. Yes. Start.
Good evening, all. Today, I will be presenting a case of a 17-year-old student. She presented to us with complaints of defective vision since 4 years of age and double vision for past 6 months. Coming to history of present illness, she presented with complaints of defective vision in both eyes since 4 years of age, which was noticed by her class teacher initially. And on evaluation, she was advised to use spectacles regularly. At 7 years of age, that is in 2016, she first visited GMC Thrissur, and as per record, her best corrected visual acuity was recorded as 636 in the right eye and 660 in the left eye. And the defective vision was painless, gradually progressive in nature, and there is no history of flashes or floaters. At 10 years of age, that is in 2019, along with spectacle correction, atropine eye drops was also started as myopia was progressive. After 1 year of atropine therapy, that is in 2020, as per records, her best corrected visual acuity was 6.9 in right eye and 6.12 in left eye. And then atropine was continued for 2 years, and then it was stopped in 2021. Patient was lost to follow-up for 3 months, and she went for an Ayurvedic treatment where she discontinued atropine as well as glasses were also discontinued. 6 months later, that is almost in 2022, when she came for review again, her axial length progression was noted, and we restarted atropine eye drops. So this was a progression note of her visual acuity. In 2017, it was -9 in right eye with best corrected visual acuity was 612. And in the left eye, it was -10 with it was improving to 680. Then in 2019, when she came for review, we noted that her correction with the it improved. It was like from -9, it got worsened to -11, and the vision was 612 in right, and left eye it was -11. Visual acuity was 680. So we started her on atropine eye drops, and then she was on follow up and for 2 years. So in 2021 when she came, though her visual acuity remained same, her progression, that is there was like from -11 it got percent to -13, but still her visual acuity remained 6.9 and 6.12. Later we lost follow-up for some time, she went for some Ayurvedic treatment, and when she came back we noticed that her axial length was progressing, like it from 29 it was worsened to 30 in right eye, and in the left eye from 29 it was like 31.202. But her visual acuity remained same, like 6.9 in the right, and in the left eye it was 6.12. And in 2023, at 15 years of age, she developed sudden onset vision loss in left eye, and she was diagnosed as rheumatogenic RD, and she underwent scleral buckling in the left eye, and laser treatment was done in the right eye. 4 months later, recurrent RD was developed in left eye, and she underwent a pars plana vitrectomy and silicone oil injection in the left eye. Following silicone oil removal, that is 6 months later, she noticed double vision, more on looking towards the left side. And 6 months later, again, she underwent a cataract surgery in left eye, that was phaco with toric IOL. Past history, there is no history of any systemic illness. And coming to family history, there is a history of defective vision both in her father as well as her paternal grandfather, who were wearing spectacles, which were both of them were myopic, and her father has to undergo surgeries for retinal detachment as well as cataract surgery in both eyes. Developmental history: she is a second child of non-consanguineous marriage. Her antenatal, prenatal, and postnatal period were uneventful. And full-term normal vaginal delivery, her birth weight was 2.6 kg. There is no history of any ICU admissions or no developmental delay. There was history of febrile seizures, and she was on treatment for up to 5 years of age. Personal history: she follows a vegetarian diet. Her sleep and appetite was not altered. Bowel and bladder habits regular. General examination and her systemic examinations were within normal limits. Coming to ocular examination, her visual acuity in right eye was 2-meter counting finger with -16 D sphere. It was improving to 612, and near vision was N6. In the left eye, uncorrected visual acuity, it was 3/60, and there was no improvement with glasses. It remained 3/60. Retinoscopy was done at 2/3 distance with tropicamide plus phenylephrine eye drops. So in the right eye, the horizontal meridian, it showed -14.5, and vertical meridian -16. It is compound myopic astigmatism in the right eye. In the left eye, the reflex was little dull because of media clarity was less in that eye. So it showed a horizontal as well as vertical meridian of +1.25, symbol myopia. Head posture was normal. There is no facial asymmetry, no proptosis, or no nystagmus. Ocular movements: Adductions and versions were full and free in right eye. In the left eye, there was -3 limitation on abduction and limitation on lever version, lever elevation, and lever depression. Hirschberg's test, it showed 15-degree left esotropia, and on cover test. On covering left eye, the right eye moves from in to out to readily take up fixation, and on covering right eye, left eye moves from in to out to take up fixation. On uncovering right eye moves from in to out to take up fixation. An alternate cover test showed an alternating esotropia, and modified Krimsky test was done, and it showed 35% diopter esotropia, and stereopsis, gross stereopsis was present. Diplopia charting was done at 1 meter with red-green goggles with red in front of right eye and green in front of left eye. It showed an uncrossed horizontal diplopia with maximum separation of image in left gaze. Diffuse torchlight and slit lamp examination, right eye. Orbital margins are intact. Lid and adnexa are normal. Conjunctiva was normal. Sclera normal. Cornea was normal. Anterior chamber depth, peripheral anterior chamber depth was equal to half corneal thickness. Iris was normal in color and pattern. Pupil was round, 3 millimeters. Direct reflex and concentric reflex was brisk. Lens was clear, and applanation tonometry was 12 millimeters of mercury in the right eye. In the left eye, orbital margins were intact. Lid and adnexa was normal. Conjunctiva was normal. Sclera showed scleral thinning, and the portion of scleral buckle was visible through the thin sclera. Cornea was normal, and AC depth, peripheral anterior chamber depth was equal to 1 corneal thickness. It was equal to corneal thickness. Iris was normal in color and pattern in the left eye. Pupil was round, 3 millimeters. Direct and concentric reflex was brisk, and lens, there was posterior chamber IOL in situ with primary PCO in the left eye, with applanation tonometry shows 12 millimeters of mercury. Fundus examination in the right eye, it shows red, distant direct ophthalmoscopy, red glow present, and media was clear. Disc and vessel seen. Disc was normal in color and shape. Disc size, vertical diameter of 1.4 and horizontal of 1.3, and applying correction factor of 1.3, it is 1.82 and 1.69. Disc margins were well defined. Cup disc ratio of 0.3. Neuroretinal rim was pink. Arteriovenous ratio of 2:3. Foveal reflex was present, and it showed a tessellated fundus in the right eye. This is the fundus picture of right eye, and in the right eye, there was a laser mark, that is a well-circumscribed pigmentary lesions were seen are almost 4 to 5 disc diameter away from the superior margin of the disc in the superior quadrant in the right eye. Left eye fundus examination, media was hazy due to posterior capsular opacification. Disc and vessels were hazily seen. This is the fundus of left eye. Disc margin well defined. Cup disc ratio of 0.3. Neuroretinal rim was pink, and there was peripapillary atrophy. And also in the left eye, 360 degree, there was laser marks 360 degree in the far periphery could also be visualized. Provisional diagnosis, pathological myopia, both eye, post-rhegmatogenous RD, left eye, post-scleral buckling, left eye, post-pars plana vitrectomy with endolaser and silicone oil injection in the left eye, pseudophakia with posterior capsular opacification left eye and alternating esotropia.
Good. So, shall we discuss the refraction component first? Push to the retinoscopy slide first. Yeah, correct. Put it on full screen. Why did you choose 2/3 of a meter?
So, so here we does it in 2/3 meter.
Why did you choose 2/3 of a meter? Why did you use one meter?
Retroscopy can be done at 1 meter, and also it could be done at 2/3.
Any specific reasons or any choice, or just it's arbitrary? You can use at whatever distance you want. In this kind of high myopia patients, do you think the reflex will be clear or dull?
In high myopia, it would be dull.
So how to make the reflex better? How can we judge that reflex better? How can we make
Distance,
the reflex
we can make the distance.
brighter?
Distance could be reduced.
If the reflex is dull, can you do a good retinoscopy? You need a good reflex, no?
Yes, sir.
What are the ways to do that? Do you know about the concave mirror option in a streak retinoscope? No idea. You don't know. There is a concave mirror option in the streak retinoscope, which will show clearer reflexes, clearer shadows, even in odd eyes, high cylinders, or these kind of high ametropia cases. So in that situation, you can use the concave mirror option. But the only thing in a concave mirror option is everything will become ulta, like with movement, add, or plus lenses, and against movement minus lenses, that dictum will change. That dictum will become vice versa. So in a plane mirror option only, most of the times we use the concave mirror option in certain cases. One of those more possible cases is this kind of a high ametropia. From here, how do you arrive the correction? You have minus 16, one axis is neutralizing, minus 14.5, one axis is neutralizing. How do you arrive from here? What are the subsequent steps which will get you the correct glass prescription power?
First, we have to neutralize one meridian with
Will you do a distance correction?
distance correction has to be done, and also drug correction has to be done. Cycloplegia
Distance correction is how much here?
Here it is 2/3 distance we have to subtract.
Subtract how much?
0.5 plus 1. So it is 1.5.
So you have to algebraically add minus 1.5. So the minus 16 will become minus 17.5. Yes or no?
Yes, sir.
So that way you will get a distance correction done. And subsequently, the next step is to, after distance correction, what do you do?
After distance correction, we have to actually, so in the, if after subtracting 1.5 from minus 16, and that is in both meridian, we have to correct first. After that, we have to take that common number, like if it is 16, it will be like 17.5 in vertical meridian, and horizontal meridian it will be
Correct. You are telling it
16.
rightly, but you're not phrasing it rightly. So the examiner say that the lowest sphere will be the sphere. Of the two spheres, the lower sphere will be the sphere. The
Yes, sir.
difference between the other
Two
the two,
will be the
two
cylinder,
spheres will be the cylinder.
and the axis
And the
has to
axis
be
will be
the opposite one.
axis will be in the meridian where opposite perpendicular meridian to the meridian where you want it to act. Okay. So that is how you'll say that. Should they allow you to calculate and say, then you use a paper, calculate and tell that correct power. Do you need drug correction here?
Yes, sir.
Why?
Because
Which is the drug used here? Which is the
Here-
drug used here?
here it is topicamet plus phenylephrine is used.
So, do you need a drug correction?
For topicamet it is one.
Okay, I'll tell you the answer. Remember it. You will apply the MAD rule here. The MAD rule says myopia, astigmatism, and phenylephrine, there is no drug correction. Do you have myopic astigmatism here?
Yes.
So there is no drug correction. So the drug correction will be only applied in an hyperopic value. To a myopic value, it will not be done. To an astigmatic value, it will not be done. To a phenylephrine also, it will not be done.
Okay.
Frozen is the commercial name for phenylephrine previously. So that is what we are still using, and that is called the MAD rule. Remember it. Okay. And the other eye will it get drug correction? Plus 1.25 plus 1.25.
Plus 1.25.
Will you have drug correction in the other eye?
After drug correction and distance correction, it is like coming to minus 0.25.
Correct. Very good. After distance correction, it will become minus
Minus 0.25.
0.25. That is one reason. So that is myopia. You won't have drug correction. Point number one. Point number two, that's a pseudophakic eye. So there is no drug correction. For aphakia, pseudophakia, no drug correction. Remember it. In the MAD rule, the A also stands for aphakia and pseudophakia. So for myopia, no drug correction. Astigmatism, no drug correction. Aphakia, pseudophakia, no drug correction. Phenylephrine, no drug correction. Understand? So in that way, in this case of yours, drug correction is not needed. And can you give a prescription, glass prescription to this patient? What is his problem now if you give a glass prescription?
Now we cannot give because in left eye the media is not that clear. And
We'll presume there is this much of anisometropia in a normal person. We'll presume this person is a normal person and there is so much of anisometropia. Can you give a glass prescription?
no.
What will happen?
Actually, amblyopia.
What is anisoconia?
Anisocon is the
Anisoconia is the retinal image size disparity.
pupil
Retinal image size disparity.
size.
So this minus 16 eye will show a magnified image or a minified image?
Minified image.
Minified image. The near normal power, emetropic power will have a normal image.
Normal image.
So your cortex cannot resolve these two imageries. It will have diplopia. So the patient is forced to wear what? Should you give refraction correction in this patient? What is the only option now?
Contact lens.
Contact lenses. Will there be contact lens induced diplopia?
Yes.
No. Contact lenses usually don't have that much of retinal image disparity. So they will not have much diplopia. So in these patients, you can use contact lenses. Understand? How will you arrive at contact lens power for this person? Your glass prescription power is ready. You have to go for contact lens prescription. What is the way you proceed to get a contact lens prescription? Do you need any more values, or just like that you can write the same power? What is vertex correction?
Vertex distance correction
What
has
is vertex
different for
correction?
high.
What is that?
Mm,
No idea.
When changing from
Is this
spectacles to contact lenses,
from spectacle to contact lenses? How do you change the power?
we have to calculate the contact lens power as the there is spectacle power by
Any spectacle power beyond
divided
4 will have a vertex correction. If it is minus and above, minus 4 and above, it will reduce. Any plus 4 and above will add up. Okay. So this power will reduce. So the spectacle power, whichever you get, will reduce when you give glass prescription for this person. When you give a contact lens prescription for this person. For the cylindrical power, can we give it in contact lenses? There is a cylinder need, yes or no? How much is the cylindrical need?
1.5.
1.5. So can we give it in contact lenses?
Can be given.
Can be given. So those kind of contact lenses which have cylindrical power in them are called toric contact lenses. Yes, correct. Do you know the Lars rule? What is the Lars rule? LARS. What is that Lars rule? When you're doing a contact lens fit on a toric contact lens, you will do a trial fit and see if there is a rotation left side or right side. You will add
Yes,
for left
we have
side
to
and
add
subtract for
and
the
right. We have to
correct. That is
subtract
called the Lars rule. So go read about it
for
and
right
become
side.
more convinced about that. That is a very important rule which you will apply in these kind of toric soft contact lenses. Any other option is there? Refractive correction, right eye. Patient is not willing for a patient is not able to adapt to a contact lens. What shall we do? What other forms of correction are available for this person, right eye? Anything you know about ICLs? Can you tell me something about ICL?
Intracorneal.
Yeah, please. Intracorneal
Implantable columnar lens.
lenses. Very good. Those kind of lenses can be used in this person. Can they be used? Not sure.
It can be used, sir, for high myopia.
It can be used. It can be used.
Can be used.
Yes, correct. What are the plus and minus? What are the advantages? What do you think are the disadvantages? Tell me at least one advantage and one disadvantage.
In patients where plastic or PRK like surgeries cannot be done, we can go for eye.
Why PRK cannot be done in this person? Why are you so very confident PRK cannot be done in this person? Why? What point you are using to say that PRK is not possible in this right eye? If you want to get this much power down, how much of corneal tissue you have to ablate? For one dioptric power, how much of corneal ablation is needed? Thickness ablation, stromal ablation. To correct one power, one diopter, how much of corneal tissue ablation is needed?
PRK is like 90%.
PRK, we don't need to ablate.
No.
We don't need to raise the flap, but we need to ablate. Only if you ablate, you will get correction. And that ablation for this kind of a power, of almost this kind of a power, will be very huge. It will be roughly around 15 microns per diopter. So if it is to be roughly around 15 power, then it will be huge. That much of corneal thickness the patient will not have. So you will not be able to do stromal ablation in these patients. Then you will get what problem? If you over ablate a thin cornea, what will happen?
Ocular integrity will also be less.
Correct. You will have ocular corneal ectasia. Corneal thinning will happen and cornea will become keratectasia. So that should not happen. Then this myopic progression will happen. Understand? Can this person be a keratoconus suspect? Can this person be a keratoconus? Possible. Do we suspect keratoconus in this person?
Yes, a bit.
It is possible.
Yes.
It is possible. Though the axial length is 31 millimeters, though you have axial elongation, still this kind of high myopic irregular astigmatism. Do you have an high myopic irregular astigmatism in this person?
Yes, sir.
Have or not?
Yes, sir.
So in that kind of a scenario, it is better to do a corneal topography and see what ratio. What ratio you have to see?
Kitna percentage?
Go read about that. The markers in a corneal topography which says that the patient has a suspected keratoconus or a form of Rustay keratoconus should be seen in these patients. In the other eye of this person, silicone oil is still there or removed?
It is removed, sir. 6 months
It is
back,
removed. It is removed. So a buckle on a high myopic person will be reducing the refractive power or increasing the refractive power. In eye which is already 31 millimeters axial length, if you do a buckle, what will happen to that eye?
Axial length will decrease.
Axial length will increase. Yes or no? Decrease or increase?
It should decrease.
How will it decrease? Buckle will always increase the axial length. You understand? Buckling is done circumferentially, no? So the axial length will always increase. If the axial length increases, then you will have a wild scenario. Already it is 31 millimeters, so there will be still more elongation of the axial length, which will not be suitable to correct. The myopic progression will become so much. So in that state, they have done an IOL surgery. Yes or no? They have done a phaco IOL. Probably the silicone oil made a early cataract in this person, and you got a cataract, and the cataract surgery was done. Now you have a PCO. Do you have a PCO?
Yes, sir.
Is it easy to treat a PCO in a high myope of this kind?
No.
What are the issues? If you have a PCO in a high myope, what are the issues? YAG laser is good for a RD patient or bad for an RD patient?
There can be increase in IOP.
YAG laser is usually deferred in high myopes because YAG will produce profound vitreous syneresis, and that will not be good for a high myope who is already having lattice degeneration, and that kind of susceptible RD patients, YAG should be deferred. Okay. What is clear lens extraction?
Procedure is done usually above 40 years of age as a refractive.
Will you advise clear lens extraction for the right eye of this person?
No, sir, no.
Patient is saying, Madam, you do surgery in the right eye and I want to avoid glasses. Can we offer, somebody has offered clear lens extraction. Is it correct or wrong?
No, sir. She is
What
only
are the
17 years, so
disadvantages? If we do a clear lens
ideally it is
extraction,
done above 40 years of age.
so age is
Accommodation.
the only criteria, no other criteria there. What are the points that we should think about when we do a clear lens extraction in this person?
The patient will be having accommodation. There won't be any, no longer accommodation will be there.
That is the last problem the patient has. The patient will not be bothered about it. His near vision will be very good. All these myopes have very good near vision. So I don't think that will be a big issue he'll raise. What are the other things? What is effective lens position? What is ELP in these kind of scenarios? What is ELP? Go understand what is effective lens position and how it affects a cataract surgery in these kind of high myopic persons. What A-scan formula can we use in these kind of very large eyes? What A-scan formula will be suitable for these eyes? What are the A-scan formulas you know of? Tell me some A-scan formulas you know.
RK formula.
Okay.
Um,
Probably you're not strong there. There are a lot of A-scan formulas, and they are grouped into two. Some A-scan formulas which will work very good in these kind of long eyes. Some A-scan formulas which will work in short eyes, and some A-scan formulas that will work in normal eyes. So your eye here, 31 millimeters, is a long eye or not?
It's a long eye.
So these kind of patients, if you try with the regular eye scan formula, you will not get a correct IOL calculation. You have to go for specific formulas here to get the correct. Understand? The patient has a lattice degeneration. What has been done for that?
In the right eye, barrage laser was done prophylactically once in the left eye RD was diagnosed.
Very good. So if the barrage laser has been done, what are the advices you'll give to the patient? A high myop, barrage
We have
laser
to
done. What are
advise
the
the
advices
patient
you'll give to the person?
that since the since the
What
left
will
eye
you
is
say to the person?
since the left eye had RD, so the chances of RD in the right eye is also more. So we have to explain the symptoms of retinal detachment, like when there is flashes or floaters, you have to report back immediately.
Very good. So you will make them aware of flashes and floaters. Yes, sir.
Yes, sir.
Can they lift heavy weights?
We have to advise them to avoid straining, lifting heavy weight, which
When
can
they
predispose.
should come for review?
We have to um, 1 to 2 weeks. 2 weeks.
Yep. A barrage done person, a lattice is there, you have spotted it, you have done a barrage. When will you see these patients again? When will you
2
ask
weeks.
them to come for follow-up?
1 to 2 weeks later.
Okay, 1 to 2 weeks later, what are you going to see at that time? Patient has been done LASIK, barrage laser, 2 weeks down the line, what are you going to see? What will you see?
We have to see the extent of the lattice or
Very good.
retinal
Then
lesions.
will you indent and see?
We have to indent and see if the barrage is adequate or not.
Very good, correct. And for any fresh lesions, you'll see.
We have to see for any fresh lesions.
And will you try to spot whether PVD is there or not?
Yes, sir. We have to look for PVD. If PVD is there also, the chances for retinogenesis RD is more.
So that much more advice you will give to the person and make him come for at least frequent follow-ups. What is SOS review? When do you write SOS review?
As and when required, we have to explain to them these symptoms, and when they require, they have to come immediately.
Very good. So when the patient has a flash or a floater or a defective vision or a curtain in front of the eye, he should come for immediate follow-up. Why do these flashes occur in these persons? Why do these flashes occur?
Because of that pull, that
On what? What is pulling which structure? Which structure is pulling which structure?
posterior vitreous.
Posterior vitreous is adherent to what?
Adherent to the strongest attachments.
To the retinal attachment. So just because it is pulling, you get a flash. What is that which creates? What is the scientific name for a flash? Photopsia, correct. So you aren't very clear why this photopsia is actually created. You are saying like vitreous is strongly adherent to the retina. We all understand that. But in certain people, no flash occurs, but RD straightly occurs. No.
Because of that mechanical stimulation of that retina.
Correct. Mechanical stimulation of the RPE, mechanical stimulation of the photoreceptors, mechanical stimulation of the which layer?
The photoreceptor layers, they are not designed to pull or respond to that mechanical pull. So the brain interpret it as light.
Very good. Very good. In this person, the person is asking, what can we do for the left eye? Is there any suggestion for the left eye? 1/60. What is the vision now? Residual vision in the left eye?
3/60.
3/60. Can we improve it?
Hmm. Hmm. Minimal benefits, sir.
What? Come again?
Minimal benefit. There will be poor vision because there was RD surgery initially was done, then again failure was also done. So the vision improvement is
So visual improvement
capacity
is very, very,
very
very almost very far-fetched in this case. As you said, lot of things are there. So this person is now almost a one-eyed person. Yes or no?
Mhm.
So in this eye, person is asking whether the right eye will get will be how to protect the right eye. What are the advices you'll give?
Since we have to ask them to avoid uh, trauma to the right eye,
Very
even a
good.
trivial
Trauma should be
trauma.
avoided. So person is asking, madam, you are giving glasses. What lenses shall we use in the glass to avoid trauma? Is there any protective glasses available for these persons? What material choice you will use for those glasses? Should you give a spectacle in this person? What material can we use? In your spectacle, the spectacle which you are wearing, what material is there? What is it made of?
Uh,
Correct. Come again. Correct.
polycarbonate.
Polycarbonate. Correct. So in these kind of high myopic persons and children and persons who are in contact sports, persons who operate heavy machinery, persons who are one-eyed, we can give polycarbonate lenses. These polycarbonate lenses are impact resistant and they'll be more protective. What are the lenses you are wearing? No idea.
Glass.
What you are wearing is CR39. CR39 stands for Columbia Resin 39. These are the resin lens, the ordinary lenses which are today commercially available. But in special situations, like in your patient, you have to use a polycarbonate lens. Okay. This person is 42. What is the age?
She's 17 years.
17. 17. 17. So more so polycarbonate lenses should be used in these patients. What are lenticular lenses? This kind of a -16 kind of a lens will be thin or thick?
It will be thick.
It will be thick. So it will be cosmetically good or bad?
Cosmetically, it will be
It will
bad.
be very bad. It will be very bad. In fact, the spectacles will show the edges very, very grossly. The edge will be very ugly. So to prevent an edge being very thickly shown, what are the possibilities in the lens choice? How can you choose an appropriate lens to get this kind of problem settled?
The refractive index can be increased.
Correct. What you're saying is correct. You can go for high index lenses. We can go for high refractive index lenses. What is the normal refractive index commercial lenses? 1.5, 1.53. These are the normal index. So if you go 1.6, 1.7, then they become high index lenses. So these high index lenses will be useful or not? They'll be very useful because they'll be thinner compared to a normal lens. So patient acceptance will be more. And similarly, another design is called a lenticular lens. Go find out what is a lenticular lens and how come a lenticular lens will help in these kind of high powers. Okay. In these kind of high myopic situations, what all distortion the patient can get? What are the visual distortions, visual aberrations a person of this kind of high power will get? Go read about them. Go try to understand what is spherical aberrations, what is barrel distortion, what is chromatic aberration. Okay. What are the aberrations which can occur in these kind of high powered lenses and how to prevent them in a normal person? This person has, you are very specific about the family tree, no? You are telling about the pedigree chart. Why were you very specific about the pedigree chart of this person?
Genetics plays an important role in pathological myopia or
Very
in
good.
myopia.
Very good. So the genetic transmission is very high in a pathological myopia. Correct. Correct. Very good. So how will you define that? When will you say a person has pathological myopia? How will you brand somebody as pathological myopia? What are the criteria they should satisfy?
High myopia more than -6 diopter.
Very good.
And axial elongation of more than 26.5 millimeters with degenerative.
Axial length more than
26.5.
20.5. 20.5 is not correct.
26.
28.
More than 26.5, sir.
26.5. Okay, correct. 26.5 then.
With fundus degenerative changes.
Very good. Fundus degenerative changes. Somebody is saying progressive myopia. Somebody is saying this person is not pathological myopia, she is progressive myopia. Well, how will you differentiate those two?
In progressive myopia, it is there is more than 0.5 diopter per year increase.
Okay, okay, correct. Any other point to say differentiate between progressive myopia and pathological myopia?
There won't be any fundus changes can be there, but
correct, correct, true. Pathological myopia, you have already told. Progressive myopia can also be above 6 diopters, but fundus will not show much degeneration. And patient usually will improve with refractive correction to 6.6. Pathological myopia usually will have some residual defect. They will not come to 6.6. They'll come to 6.9, 6.12 parts, like that only their vision will be. You understand? So this is how you'll differentiate pathological myopia and simple myopia and progressive myopia. What are the other retinal changes you expect in a pathological myopia? One is lattice, we discussed. What are the other changes you'll expect? Degenerative changes in a pathological myopia.
Lacquer crack,
Lacquer cracks,
posterior staphyloma,
posterior staphyloma, correct.
posterior peripapillary atrophy,
Peripapillary atrophy, correct.
tessellated fundus.
Tessellated fundus,
There can be tilted disc,
tilted disc,
posterior fused spot,
posterior spots,
maculopathy. There can be macular diffuse chorioretinal maculopathy or
very good, very good, correct,
chorioretinal maculopathy, macular atrophy,
correct.
choroidal neovascularization. There can be dome-shaped macula.
Correct. Person is having peripheral degeneration, but your doctors are saying no need for barrage. What are the types of peripheral degenerations which don't need to be treated?
White without pressure.
White without pressure. White without pressure needs to be treated. White with the pressure, you need not treat it.
White with pressure in order to treat.
And other degenerations?
Lattice degeneration.
Lattice degeneration is one. Is there any other degenerations of interest?
Snail track degeneration.
Correct. Snail track, snowflake,
Snowflake.
chorioretinal atrophic patches.
Cystic tuft degeneration.
Tufts, retinal tufts, correct. Every lattice should be barrage. What are the points in a lattice to say that we can observe? What are the points to say that we have to immediately barrage?
If the fellow eye has a that is if the lattice involves a hole, if it is a horseshoe tear,
Lattice will not have horseshoe tear. Take it from lattice will not have horseshoe tear. Lattice will have what tear? Lattice will usually have atrophic round holes in them. It will not have an horseshoe tear. So should you see a hole, you will barrage. Should you see a thinning, you will barrage. Should you see a dense vitreous condensation to the margins of a lattice, you will barrage. If there is lot of symptoms in the person is saying I am having flashes and floaters, you will barrage. If, as you said, the other eye is RD, you will barrage. Understand? A person who is not very close to the hospital, who might be lost to follow up, who doesn't understand what you are advising him, then you will barrage. And all other patients you might observe. You don't need to barrage every lattice. What laser is used to barrage? What laser do we use? In your hospital, what laser is being used?
in India,
NDR? That is used for posterior capsulotomy, iridotomy only. We don't use it for barrage. For barrage, what is used? What will happen if I frequency double a NDR? What will happen if I do a frequency doubling of a NDR? Go find out. What is Nd:Arc's frequency? What is its wavelength? Should I do a frequency doubling? What will become the wavelength? What do we call the green lasers? What is used? How is it used? Where is it used? Have you done laser photocoagulation?
No.
So you aren't aware. So probably you'll have to read up and catch up that area. And more about high myopic correction. There is lots given in Dukelder. Open Dukelder and read about what are the surgeries done on the cornea for high myopia and what are the surgeries done other than the cornea and high myopia. Any idea you have? Can you answer that question? What are the surgeries done on the cornea? What are the surgeries done elsewhere in an eye for high myopia? Go read about it. Go try to understand what are the corrections which are done for high myopia on the cornea and what are done away from the cornea. Okay. Malika madam, I think we have come 1 hour with her. So we have also she has answered nicely, but certain areas she has to brush up.
Yeah, sure, sir. Yeah, I understood. Actually, it becomes an eye opener for them. Where do they stand, and what all domains they have to get more. They have to work up themselves to become more stronger, and so that they can answer perfect. Yeah,
Correct.
they have to. Yeah, it is actually it was a wonderful thing for so many. Residents are watching this, I'm very sure that today's discussion, it must have proved highly beneficial for them. They are for everybody. It would have been it's a test for them. How do they stand? How strong they are in refraction and the refractive correction. So it will be a very, very good homework for them to become more strengthen their refractive error. Knowledge training. Thank you so much, sir.
In fact, this is the toughest case. It can go into retina, it can go into
Yeah,
refraction, it can go into contact lenses, refractive procedures. We can go into discussion of any area in this case. It gives lots of scope for discussion. And
it's
so
true. I know.
PBs when are there the exam, their mind will be focused on one thing. They'll be like premeditated to answer refraction questions. Suddenly you go and ask something on the buckle, then they'll be lost. Suddenly their mind will not switch from here to there. So they'll have a answering that. So they have to be open-minded when they go for exam with these kind of cases, because examiner, whatever he likes, he'll start questioning. So they'll have to be ready for such kind of question.
Dr. Najat, you can stop sharing the slides.
We should get some feedback from the student also, sir.
Yeah. Usually, they also take part in the discussions, but this time only the presenter was answering all the questions. But it was well presented, sir. And of our 21 modules, this is the first case, refraction case is presenting. So always it is cornea, retina, uvea, like that. The refraction case never came.
Yes. Here in refraction cases, we'll stress on the calculations. She arrived at the retinoscopy power. From the retinoscopy power, the final calculation till she get a glass prescription. Then probably another time. I wish that another time we do that also. In a regular case, high myop, so she gets biased with that high myopia. A straight case if she does, then she will learn lots, because refraction discussion is something very special. Most of the time students are not doing it regularly. Other cases they see regularly. Refraction at least to an answering point, they are not very much exposed. So that will help, madam. I believe that more of that cases we can add in this virtual class.
Yeah, sure. It's a great pleasure.
Thank you, madam. Thank you,
sir. A lot of learning points. A lot of areas you touched.
Yes,
And
sir.
I hope that all the PGs who attended this program and who are going to attend this program through the YouTube will be benefited. And anything else, Malika?
Yeah, nothing. Yeah.
And-
I would like to thank especially Rajasekhar sir for his very active discussion and very good teaching method. He's a very good teacher. I know that's why I perfectly chose the right person.
Yeah.
He was the right person to be there. Um, yeah, I'm also thankful to Dr. Bastin and Dr. Najri and all participants who actively who are not at all actively participating but all watched it. So many
Yeah.
people watched it, all residents. I'm very sure that all got benefited by this teaching session. Thank you so much. Thank you so much, everybody.
Thank you, madam. Thank you.
Okay.
Thank you, sir.
Right.